Hello. Are you tired of quick fixes that promise transformation but leave you feeling more disconnected from your body than ever? Welcome to the Beyond Medicine Humanized Care for Women of Influence, where we go deeper than surface level solutions. I am Dr. Maria, a functional integrative physician specializing in women's health, metabolic dysfunction, and hormone balance. Here we will uncover the root causes of insulin resistance, PCOS, thyroid, and adrenal issues, and explore how trauma, stress, and anxiety impact our well being. Because your body's not a microwave, it deserves personalized, compassionate care that honors its complexity. So let's embark on a journey to reclaim your health one conversation at a time. Today, I have with me in podcast Dr. Dana Gibbs, who is a board certified ENT physician. She is the owner of Consultants in Metabolism, a micro practice in Texas. So, thank you to the show, Dr. Dana. And can you start by telling us a little bit about you and what you do in your day to day? And also, tell us the story of how you ended up from nose, which is what everybody associates ENT with, to hormone.
Thyroid. Yeah. So, hi. Absolutely. I am so honored to be here. Thank you for having me. I am Dana Gibbs. I am an ear, nose, and throat specialist by training, as you mentioned. And my current practice is focused on metabolic health. It's funny how closely our missions align. Metabolic health and particularly chronic fatigue that is related to various thyroid imbalances.
Hmm.
And how I got here is a little bit of a convoluted story, but I'll try to give you the TLDR version. So, I personally had a very tough time during
Mm,
my late teens and 20s, college, and up through even into my 30s with energy and brain fog and feeling weak and tired and sleepy and I went to the doctor several times. They said, no, you don't have allergies. No, everything's fine. Here, try these antidepressants. And 20 years later, when I was out of residency, out in private practice, I was learning allergy of all things because that's part of ENT. And I was at a conference where there were some unconventional speakers, and one of the lectures was on thyroid. And I went and sat in there because it's embarrassing to say I went and sat in there because was bored with the other topics that I had already heard
mm,
it half a dozen times before. And so I sat in this guy's thing and he was talking about hormones. And one of the first lectures was about thyroid. And he put up this list of symptoms. And it was brain fog and cold hands and feet and low blood pressure. And your eyebrows fall out and your hair is thin on top. And all these things and, mood changes is part of that. And by the time he got to the bottom of that slide, my jaw was hanging on down to the floor because he was talking
mm,
about me. Everything he had said was me. I had gone and had my TSH checked before and they were like, "Oh, you're fine. It's not your thyroid," and all that cool stuff. This guy said, "It doesn't you don't have to have an abnormal TSH to have abnormal thyroid function." And I was like, "Holy cow, he's talking about me." And so I started looking into it. I started basically experimenting on myself. And the first time I put Armor Thyroid in my body, it was like, "Holy cow, is this what normal people feel like?" It was a total
mm,
miraculous change for me. And, it just drove me even harder. Okay, why did this work for me? Why do people have this abnormal feeling without abnormal TSH? And I finally found a mentor who could explain it to me. It took a while, but I finally found a mentor who explained all the things and how thyroid interacts with cortisol and with your stress hormones and with your insulin and with your sex hormones and all the other things that it does.
yeah.
But meanwhile, I'm still an ENT doctor. And one of the things ENT
Mm,
doctors do on a routine basis, not every single ENT doctor, but a lot of us, is thyroid surgery.
Mhm.
And people don't think about that. And so people get referred to an ENT surgeon because they have a knot or a lump in their thyroid and they're worried that it's cancer, or they have a goiter that some other doctor thinks needs to be removed because it's either compressing their breathing or there's worry that it's cancer, whatever. When I was in residency, all the people that we saw and all the people that we did surgery on were severe cancers, large
Mhm.
goiters. The extreme ends, and this is academic medicine, right? So you're getting these tertiary referrals of people who are kind of in the extreme. And then when you get out in private practice, the patients that get referred are, oh, well, they have a nodule that's about less than an inch across. And the the things that we do an ultrasound, we do a needle test, and they say, well, there's a risk it might be cancer. So we go in there and take it out. I very quickly noticed that 95 or plus percent of those people were not cancer. As a matter of
Mhm.
fact, the pathology came back chronic lymphocytic thyroiditis. And I'm like, what is that? What does that
Mhm.
mean? What is that? What that is Hashimoto's disease. And Hashimoto's disease is the most common reason for people to have thyroid nodules. And it's not a surgical disease. The Hashimoto's nodule is something that's not going to hurt you. As a matter of fact, what it is, your thyroid is trying to recover from the Hashimoto's disease and it's producing new thyroid tissue, but it's bound up in scar. And so it becomes a round blob that looks like a tumor. And so we just took out a piece of thyroid tissue from your thyroid that was trying to recover from a disease. We just made you worse.
Mhm. Mhm.
And the more I did that and the more I sent those people off to the endocrinologist to get put on levothyroxine and come back and they've gained 40 pounds and their hair fell out and they feel like crap and they're depressed and all the things. I was like, I'm not helping these people.
Mhm.
And then when I
Mhm.
came across this, oh my gosh, not everybody who has thyroid problems has an abnormal TSH, then I was like, okay, this is there's really something here. And so I
Yeah.
started, instead of just sending my surgery patients off, I started saying, okay, one for one, if we think this might be a Hashimoto's nodule, why don't we try treating you first with medicine before we go doing
Mhm.
surgery that's going to make you worse? And so I
Mhm.
learned a technique that was in the textbooks, but it wasn't super common, where we would give people medicine to suppress the growth of that nodule. And if it worked, then they don't have to have surgery. Hallelujah. We
Mhm.
stopped somebody from needing surgery. So I was the surgeon who got people to not have surgery. That was kind of the first part of it. The better I got at recognizing those hypothyroid symptoms, the better I got at balancing people's thyroid hormones. And they would come back from their endocrinologist, I feel worse. And I would say, hey, let me give it a shot. And they would feel better and they would go off and tell their friends. And the next thing I know, I got a clinic full of people with who were tired and think they have low thyroid. And sure enough, a lot of them did, based
Mhm.
on this new technique that I learned for testing people for thyroid. So as my clinic became more and more non-surgical, it became less and less important for me to be in a large clinic where it's high volume and we make a lot of
Mhm.
surgeries.
Mhm. Mhm.
And so eventually when COVID hit and medicine got crazy during COVID and doesn't seem to have gotten any better since then. And I finally just said, you know what? I'm done here.
Mhm.
I'm starting to get old. My vision's going bad. I don't love doing surgery anymore. Why don't I
Mhm.
just make a clinic where I can do what I want to do, what I really
Mhm.
love to do? And so here I am.
Yeah. Thank you for sharing that story. So there's a couple of things that I want to move back, if that's okay
Yes,
with you.
absolutely.
So one of the things that you said was like in terms of like hormone and metabolism. So women hear metabolism and they're thinking of like burning the calories,
Yes,
losing the weight and that sort of thing. And when women hear the word hormones, they're usually thinking estrogen, progesterone.
correct.
And yeah, yeah. news that hormones are interacting with one another, which I love because sometimes um, people, not only women, but people in this might be due to a lack of maybe knowledge, but also because there's so much going on the news and the media and social media. Sometimes we forget that, how the hormones interact and that you have more than just one hormone, for example, like
Exactly.
thyroid. And that, oh, it's only thyroid what I need to fix, if I can use that word.
Mhm.
So when you're thinking about thyroid health, but optimizing it from this whole person perspective,
Yes.
knowing that the thyroid is also affected by other hormones in the body. What
Mhm.
are some other hormones? I'm repeating that word a lot, but what
Yeah.
are some of the other things that women should say? Let me make sure that I'm either tested or that I know if the results are that they need
Yes.
to also pay attention if they want to optimize their thyroid health.
Sure. So the first thing that you have to understand about most of the hormones in your body is that they are controlled centrally from your hypothalamus and from an offshoot of your brain called your pituitary gland, which are up here between your eyes and your head. And the there are releasing factors that come from your hypothalamus, go to your pituitary, release things like TSH, thyroid stimulating hormone, ACTH, which is adrenocorticotropic hormone that causes you to release adrenaline and cortisol. Those all kind of go through the same pathway and they interact with each other, they feedback with each other. And then there's FSH and LH, which are the ones that release the sex hormones, testosterone, they all interact with each other. And cortisol is the master controller of all of this that goes on. And it actually indirectly controls other hormones in your body, like insulin, that isn't controlled through your pituitary gland, but it's controlled by other factors, one of which is cortisol. And cortisol is the stress hormone. And I'm sure your clients know this already, but the more anxiety, fear, pain, sadness, shame, there's these 5 negative emotions. And the more of those emotions you experience throughout your walk through life, the more cortisol you release. And the more cortisol you release, the more that feedback loop in your hypothalamus, brain, pituitary goes and pushes down on the other hormones in your body, specifically the sex hormones and also thyroid. And so, if you, thyroid is pretty simple, it's pretty straightforward. It's like you have TSH that is the signal to your thyroid to make more
Mhm.
thyroid hormone. When you have a lot of thyroid hormone, it lowers TSH and it stays balanced in theory. But the truth of the matter is, when you have very high levels of cortisol, it also pushes down on TSH
Mhm.
and it can make you have low TSH and low thyroid hormones at the same time. The other thing that it can do is that it can change how your body processes thyroid hormone, because thyroid hormone, the way it comes out of your thyroid gland, is not the active hormone. People don't realize this. The thyroid hormone has to be turned from T4, which has 4 iodine molecules attached to it, to T3 in various tissues in your body. And this happens in every tissue in your body. And the more cortisol you have, the lower that conversion is. And so you can have enough T4 from your thyroid gland and still not have adequate thyroid action in your body tissues because you don't have enough T3 or because you're making too much of another alternative hormone pathway, which is called reverse T3, which actually slows down the action of the T3. So you can have everything looking great. And if you don't check the T3 and the reverse T3, you don't know whether you have adequate thyroid function. And so people come in and they're like, Doc, I've gained all this weight. I'm so tired. I'm so sleepy. My hair fell out and I'm depressed and my brain just doesn't work and I can't remember stuff. And their TSH will be fine. Their T4 will be fine. Their T3 might even be in the normal range, maybe bottom half of the normal range. But if they have high levels of reverse T3 because their cortisol is so out of whack, then they're not going to feel normal. Their
Mhm.
metabolism is not going to burn calories for heat the way it does. Your body is in survival mode.
Good. Mhm.
Your This is kind of what cortisol is. Cortisol is a very primitive. Yes, it helps us have energy to get up in the morning and do what we need to do. But when it gets too high, it is a very primitive energy conserver because what was
Mhm.
the main stress our ancestors had? It was starvation.
Mhm.
It was starvation. And it was, okay, we've been running from the lion all week and we finally shot him and he's dead. And now we need to conserve energy and we need to eat all the things and we need to put back on all the weight we just lost because we were running from a war or a lion or whatever.
Mhm.
And so thyroid gets turned down in situations of extreme stress.
Mhm. Yeah.
And that was
And
certainly the case for me and probably what was wrong with my thyroid. So that original lecture that I went to, the guy was like, "We don't know why this is, but sometimes TSH isn't abnormal." And I'm like, "Now I know why.
mhm.
It's because I was under so much stress that my body just said, we're just not going to make thyroid hormone no more." Okay.
Mhm.
You need to conserve energy. You need to hibernate. You need to go into hiding instead of working 18 hours a day or whatever I was working. Anyway,
But I like that you mentioned, so from if I can recap, so I can assume that we can say that we want to check the traditional TSH,
yes,
T4,
yes,
T3,
yeah,
reverse 3T, and
yeah.
then
Reverse
I
T3.
go ahead.
Okay. So there's a little bit more to that. So when you check reverse T3, if you're somebody who draws labs and does this, then you need to know that reverse T3, when you order it, is total reverse T3. It's not free reverse T3. And so you can't put it next to a free T3 and compare it directly. They're a factor of 100 off from one another. And so you cannot directly compare. But what you can do is you can order a total T3 and you can then directly compare total T3 to reverse T3. And if the ratio is not 10-1 or higher, then you know that the person is inactivating their thyroid hormone versus activating their thyroid hormone, which is what they need to be doing. And so I use that ratio, total T3 divided by reverse T3. I use that all the time. I order it every time I order thyroid labs for people. And when that ratio is 12, I'm pretty happy. If it's 14, I'm pretty happy. If it's higher than 14, we're starting to get into a treatment problem. But if it's lower than 10, that means your body is trying to take away the T3 that you do have and inactivate it because it thinks you need to hibernate.
Mhm.
Does that make sense?
A- Absolutely.
Okay.
Absolutely. Absolutely. So let me recap, right? So we will do so that women know, right? So the tier stage will pay attention to their T4.
The free
They,
T4.
yeah, the free T4. And then T3 and reverse T3, you want the total. And
Yes.
then you are recommending that they do the ratio, the math of dividing. So the total T3 divided by the total reverse T3.
Yeah.
And
And like I said, in the lab when you order it, they won't say total reverse T3 and they won't tell you that it's total. And we can talk more about what that total word means. But just to make sure that we don't leave it out, we also are interested in what is your free T3. And if you are not on thyroid medicine at the time of doing labs, then you can do that lab test anywhere from when you first get up in the morning up to about 1 o'clock in the afternoon, and it'll be good. But it does fluctuate a little bit through the day
through the day.
because you don't want it to be at the maximum high when it's time to go to bed, because otherwise you got too much buzzy energy going around in your body. But the reason we need a free T3 and a total T3 is because of what's called binding proteins. And binding proteins are important because they help carry the thyroid hormone around in your blood. They are fat soluble. Like there's water soluble vitamins and fat soluble vitamins. There's also water soluble hormones and fat soluble hormones. And thyroid happens to be a fat soluble hormone. And so it doesn't just float around free very much in your blood. It has to have a binding or a carrier protein to take it around where it needs to go. And about 98 to 100 to 99.9% of your thyroid hormone is bound to those proteins. And so when it's bound, it's not bioavailable. It's not available immediately to your cells to use. And so that we need to check the free, which is the unbound, and then we need
Mhm.
to check the total. And the reason we need that total is because we have to compare it to reverse T3, which only comes in a total.
Great. So let me recap so that because sometimes this can get confusing for people.
It
So
is
they
confusing.
so ideally, what women should be look so their TSH, their free T4, their total T3, and the total reverse T3. But then they also want to pay attention to their free T3.
Absolutely.
And then the ratio that they want to do is total 3T3 divided in the total reverse T3 and aim
Absolutely.
for a number between 12 to 14.
Exactly. That's exactly
Okay,
right.
awesome, awesome. And then so going back to how other hormones, right, and the effect that it can have in the body. In your opinion, should you just say, oh, okay, so you're under stress. So, yeah, your cortisol is going to be up. So, there's a problem there. Or is your approach actually testing as well for cortisol and helping women see and understand that stress does have an effect in the health? And that is something that they need to start to think, okay, besides maybe taking hormone placement therapy, looking at my micronutrient related to my thyroid, that oh, I also need to pay attention to how I'm going to manage stress or adapt to stress.
Yeah.
What's your opinion
So,
there?
boy, that's a huge topic. We could talk all day about this actually, but I do when I'm first seeing someone for a diagnosis of chronic fatigue, I will check in the morning, I will check their ACTH and I will check their cortisol. But I will tell you that interpreting those numbers, if they're quote unquote normal, can
Mhm.
be a little bit tricky because so an ACTH that's done in the morning can be helpful if it's really high or if it's really low. That can be really helpful to know. Okay, are you getting a signal for a ton of cortisol or are you getting no signal at all? Those are super important to know. But the cortisol itself varies so quickly in your blood. I mean, it comes up within, if you get stressed by something, say somebody sideswipes you or nearly sideswipes you in your car on the way to the lab, or just you're late and you're like, oh my God, I'm late. I'm late. Within 30 seconds of that stressor, your cortisol shoots up. And so
Mhm.
if you're a chronically low cortisol person and you go to the lab and you nearly get sideswept as you walk in, or say you just hate needles. You're just like, "Oh my god, I hate getting my oh my god, hate getting my blood drawn." You'll have a normal or even a high looking cortisol even if you're somebody who traditionally has a very low cortisol. So the number of the cortisol also isn't super helpful unless it's like 0.
Mhm,
In which case you're like, okay, you have almost no cortisol in the morning when you should have a reasonable amount of cortisol. So, what I tend to do is if I'm worried about that, and the reason I would be
mhm,
worried about it is because I go through somebody's history and I want to know, were they a preemie? Did they have nuchal cord? Did they have hospitalizations when they were 0 years old? Did they have child abuse or were their parents fighting all the time? I'm looking for their stress history all the way
mhm,
back to when
mhm,
they were born or when their mom was carrying them in utero. I'm looking for that because people who are exposed to stress chronically throughout their life react very differently to people who are just real, oh, I'm even keel. I don't, nothing bothers me. They're very different patterns. And so
mm,
if somebody has had that history, I'm already suspicious and I'm already knowing, okay, they live in a chronic high cortisol state. And so they're very likely to be nutrient depleted and needing some support there. So I might actually, just before I even do their labs, I might hand them a supplement or two and say, you need to start taking this to support your adrenal glands' ability to make as much cortisol as you need. One mistake that I see people do is if they live in that land of high cortisol, is taking herbs that just knock down your cortisol, because there are
mm,
several of
mhm,
them. And the problem with taking herbs that knock down your cortisol is not only are you knocking down the cortisol, but you're also knocking down the other hormones that use that same pathway, the progesterone, the estradiol, the testosterone. And I can guarantee you, you're not going to feel better if you do that. If
mhm,
you knock down your normal production of those hormones, you're not going to feel better. And so my techniques that I have people use to lower their cortisol has more to do with mindfulness and meditation and
mm,
coaching.
mhm,
And let's change those chronically anxious, elevated, oh my God, something bad might happen to me today thoughts
mhm,
that result in the high cortisol at the same
yeah,
time as we're supporting the adrenal glands so that it can then come down naturally and still be supported. Because those extra nutrients that I give to somebody, if you don't need them, you just pee them out.
yeah,
They're not around to cause side effects. I mean, there are some herbal supplements that people use that have multitudes of effects in your body, and we don't even know what a lot of those are. And so I tend to really try to stay away from and they're called adaptogens is the name
mhm,
of them.
mhm,
I try to stay away from adaptogenic herbs that are known to suppress adrenal function,
mhm,
just
mhm.
because I really feel like it can knock down all the hormones, not just the adrenals.
Yes, yes,
So
and I
I
think
worry
that's
about.
yes, and I think that's important to mention because adaptogen, they have become, like, very popular, and they
Super
are
popular.
yes,
You can
and
buy them over
they,
the counter.
yes, and not only buy them over the counter, they're added to, like, chocolate powders and, like, the puffy mixed with adaptogens, so
Yes.
they
Oh,
have
mood
relatively
boosters and this, and it's just like they hide them in. What did I see one the other day? Somebody asked me about
in
shilajit
tea.
salt.
Yeah. Oh,
And I was like, "Shilajit salt, what is that?" And I looked it because I hadn't heard of it. I was looking it up, and the brand of the stuff that the patient was asking me about had ashwagandha added to it. And I'm like, "Shilajit salt is harmless unless it has
mhm,
lead contamination," which sometimes it
mhm,
does,
mhm,
which is this is
mhm,
what I found out when I was doing this online search. But then when you add an adaptogen to it, it's an herbal medicine, and if you don't know
mhm,
why you're taking that, you shouldn't be taking it.
mhm, mhm.
Yeah.
Yes. Yes. So I think that it's important to mention that if, that you shouldn't, I'm just going to put it this way. I don't believe that people should start taking adaptogens on their own and then
Yeah.
continue to take them forever. I think that
No,
that's the,
absolutely don't.
Yeah, that's an area. It's almost like starting sertraline or
Yes.
citalopram, like on your own, and then you
Mhm.
just continue to use it until you think, oh, it's going to be good or it's going to be better. Thank you for mentioning that. And I do believe that it's important that people hear that even thought they have become very accessible.
Mhm.
My opinion is that if you're going to use it, it's because you are under the care of somebody that knows what and that they
Yeah.
know what they're doing, not just
Yes.
because you bought it, I don't know, in the health food store.
Right.
So,
Exactly.
yeah, so thank you
Um,
for mentioning that. Go ahead.
yeah. I wanted to, because low cortisol low cortisol, because high cortisol is not the only reason why people's T3, T4, T3, RT3 ratios can go out of balance. I don't want to make it sound like the only thing you have to do is fix your cortisol and your thyroid will magically be better, because it's not always true. And I would say we can talk about what kind of stuff you want to do to support your thyroid on your own. And then before we finish, I do want to mention how I treat somebody who has a very high level of reverse T3 and low T3. I want to make sure we cover that before we sign
Yeah.
off.
Yeah. So because we have been talking about like the T3 and the reverse T3 and the ratio and doing the math. How about if we start there about, you discussing, so when you encounter a patient that maybe has a normal PSH and a
Mhm.
normal 3 T4, but then you look at the T3, the reverse T3, and you do your calculations, they're not in that range of the 12 to
Mhm.
14. So what is your approach to the patient? So let's start there, and then we
Uh-huh.
can go into how we can, as an organs of our body, how can we take care of our thyroid? So,
Yeah. Yeah, absolutely. So the first thing I want to know is, why
mhm,
is it like that? And if it's a really obvious stress history, then we can start there. But I don't just leave it at that. So I'm looking for a couple of different things. And one of the things that I'm looking at is, do you have Hashimoto's disease? Because Hashimoto's disease is an inflammatory autoimmune disease. And if you have that, then there are lots of things that you can be doing with your minerals. Um, so there are trace minerals like selenium, zinc, iron, that you need to make sure that you're sufficient in those.
mhm,
Iodine is another one. You don't want to be too high, but you don't want to be too low. I've seen a lot of people come in and someone has recommended that they take very high doses of iodine for low thyroid function. And it actually triggered them to have autoimmune, like a
mm,
flare of their autoimmune. And so you need to be very careful with minerals. But if you find a multi mineral that's a trace multi mineral and it has less than 200 micrograms of selenium and it has, I think, 300 micrograms of iodine is probably the maximum in a day that I would recommend, 3 to 500. And it has a reasonable amount of boron and zinc and all these other things. I would consider, if you feel like your diet is not sufficient in those things, then I would add that. That's a number one easy thing to do. And then the other thing is to look at possible food sensitivities, because people don't come in isolation. They come in and they've got gut problems and they've got this and they've got that. And so I'm very frequently looking for, do you have a food sensitivity
mm,
that needs to be addressed? And because I was an allergist for so many years, I have a very specific way that I handle elimination and challenge diets, because I really feel like there are lots of online you can go, and there are these very strict autoimmune paleo, these very strict elimination diets that, for the most part, I feel like really add stress to people's lives. And stress is one
mhm,
of the huge triggers of Hashimoto's disease. And so we really want to stay away from things that add stress, but you also
mhm,
don't want
mhm,
to be eating something that's triggering inflammation in your body. Then sleep is a huge thing that we have to look at. And one of the things about people with thyroid imbalances is that they sleep a lot but they don't get the benefit of it. It's like you
Mhm.
lay there in bed and your legs are freezing, your hands are freezing, and you shiver for an hour before you fall asleep. And then you wake up, a few hours later, just drenched in sweat. And it's okay. So if you have that, that is not going to go away just because you lower your stress level. That's part of the thyroid process. And so then it's like, okay, you're giving yourself the adequate opportunity for sleep and you're not getting the benefit of it. That's different from somebody who's burning the candle at both ends and staying up till 11:30 and getting up at 4:30, and I'm like, you must give yourself an 8-hour sleep opportunity. If you're not doing that, then nothing I do is going to fix that high reverse T3. Nothing
Mhm.
that I do is going
Mhm.
to fix it. And I see
Mhm.
that way more than I care to.
Mhm.
And so sleep is something that's absolutely important. If somebody is a heavy snorer or if they live alone and they don't know, I a lot of times will send them for a sleep study to make sure they don't have sleep apnea because that
Yeah.
goes right along with everything. But then when I've looked at all those other things and I've ruled out all of that, then the next thing that we've got to do is okay, you're still tired. You don't have enough energy to eat healthy. You don't have enough energy to exercise the way you know would be beneficial. Should we supplement your thyroid? And a
Mhm.
lot of times the answer is yes. And I realize there are tons of people out there who are like, ooh, I don't want to take thyroid medicine. And I'm like, I get it. I totally get it. You've been put on levothyroxine. It didn't make you feel better. You're tired of, mainstream medicine telling you what to do and not listening to you. I get it. I totally do. I was there. I was with you. But there are people who don't start to recover until we give them T3 and help boost those levels. And what happens when you take T3 is that your thyroid goes, I can relax now. I don't need to make as much T4. And if you don't have very much T4, then you don't make as much reverse T3, which is
Mhm.
great. And
Mhm.
so we carefully raise and balance a person's T3 by giving them either Armour Thyroid, which has some T3 in it, or
Mhm.
T3 alone. And T3 can be purchased as a prescription in a synthetic form. It is also something that a compounding pharmacy can get for you, but you're still getting the same basic synthetic T3 ingredients, just a matter of, okay, what additives are in it? What excipients are in it to make it look pretty, to make it stick together, to make it dissolve properly in your stomach, to make it absorb properly. One of the excipients that I don't like is that the compounders will tend to try to make you an extended release T3. And
Mhm. Mhm.
so T3 has a very short active time in your body from when your bloodstream absorbs it to when it pees it out and says goodbye, breaks it down, gets rid of it. It's about 6 hours,
Mhm.
maybe 10
Mhm.
at the very most. And there are scientific studies that show that half-life. If you take a big whomping dose of T3, by 10 hours, most of it's gone out of your body. And so you cannot take this stuff once a day. And the stuff that compounders use to make a normal medicine into an extended release medicine do not seem to work for T3. All it does is just lower the amount that you're getting.
Yeah.
And so when you're going to take T3, you got to take it 2 or maybe even 3 times a day. And I personally have switched to taking mine 3 times a day
Mm.
because I sleep much better. I don't have that 3 a.m. wake up drenched in sweat thing anymore when I take my little small amount of T3. Not the same amount I take in the morning, but that little small amount of T3 seems to help me sleep more regularly through the night. And I've always
Yeah.
been a terrible sleeper.
Yeah. So I do want to pause you right there because
Yeah.
I think that you said something that a couple of things that are important. So one, use that T3 compared to if you're using a T4 like levothyroxine, right? That
Mhm.
you only take once a day. T3, you want to take it multiple times a day, right?
You must
Um,
take it multiple times a day.
because of that like short acting.
Yes.
And then, so you said that it's about like 10 hours in your body, for the majority of the people. I'm sure that there is differences in how people metabolize it.
Of course.
Um, but I think that's something that you said that was very interesting also is the dose that you take in the morning. It's not the same dose that you take at nighttime. And I think that the reason that's interesting is because, again, we talked about, which I completely agree, sleep. We always want to make sure that people are sleeping well, right?
Mhm.
But correct me if I'm wrong. If you have too much of a T3 at nighttime, that can also kind of like activate you a little bit, right?
Right, and so this is very individualistic.
Mm-hmm.
So and you mentioned something that I wanna mention as well, which is about taking levothyroxine once a day. I have my patients break their levothyroxine and take it twice a day as well, and the reason why is because the fluctuations that you get when you take that pill once a day, they say, "Oh, it has a very long half-life," and maybe it does. Maybe it's 3 days, but it's not 2 weeks. I was taught in medical school 2 weeks. I strongly believe that's
Mm-hmm.
wrong. If you send somebody to the lab to stay there all day long and you give them a dose of levothyroxine, and then you check them 1 hour later, 5 hours later, 10 hours later, all the way up to 24 hours later, you will get a very nice sine wave, goes up and then it goes
And then
down,
down.
goes up and goes down. That fluctuation in the levels in your blood when you're taking a thyroid pill is one of the things that pushes you to have a high level of reverse T3
Mm-hmm.
because that's what reverse T3 is designed for in your body. It's designed to protect you in case you have too much thyroid in your body, which happens in
Mm-hmm.
some disease states. And one of the things that happens to people with Hashimoto's disease is because their autoimmune attack is hitting their thyroid and causing it to intermittently release very high levels of thyroid hormone, then that's your body's protection against high levels of T4 after it's already in your system. TSH is supposed to go down and it's supposed to stop you from making T4, but if you took a pill, then it's there regardless. If you have Graves' disease, it's there regardless. The TSH is meaningless. So it's the backup system to protect you against too much thyroid
Mm-hmm.
hormone
Mm-hmm.
effect in your body. And
Mm-hmm.
so I tell people to break that levothyroxine pill in half. Take half of
Mm-hmm.
it in the morning and half of it at bedtime. Now, when you
Mm-hmm.
don't want to take thyroid hormone is at dinner time.
Okay. Okay.
Because after dinner is when you're supposed to be winding down and getting ready
Mm-hmm.
for bed and going into
Mm-hmm.
parasympathetic
Mm-hmm.
and getting sleepy. And if you take your thyroid medicine after dinner, then right about bedtime, you're going to be ready to go. And
Mm-hmm.
it's like, okay,
Yeah.
that's just the opposite of what you want to do. But if you take it as you're turning out the light,
Okay.
then
Before
you're
bed, like
starting to get some, yeah, then you're
right
starting.
immediately before bed.
Yes, then you're
Okay.
starting to get some effect throughout the night. And so for some people, they only want to take their T3 twice a day. And if that's the case, then I'll have them take it first thing in the morning and middle of the afternoon. If I pick it, it's like, okay, when's your slump? Is your slump at 4:30? Great. So take it at 3:30. Is your slump right after dinner? Okay, take it at 4:30. So divided, but not exactly 12 hours apart.
Mhm.
Because otherwise, yeah, you'd be taking it at 8 p.m. right before bed. And it's just, oh, now you don't want to go to bed. So, yeah, so we do play with that and it's very individualized. But for the people who have the afternoon slump and the midnight awakening, that's me.
Mhm.
So I
Mhm.
take mine first thing when I wake up, I take it about 3 o'clock, and then I
Mhm.
take it again at bedtime. and
Mhm.
that's how I do it. For a lot of people, that's too much. It's too fussy. It's too hard to remember. So I'm saying, okay, then take yours at, 6:30 a.m. and 4:30 p.m.
Yeah.
There we go.
Mhm.
So it's
Also,
it's individualized.
yeah. And I love that. I love that approach of being individualized. And I think that the important thing to mention is that so the T4, I didn't know also about like breaking it, but definitely the T3. I think that it's important that people know that yes, you should um, take it at different times of the day, like one in the morning and then another one in your afternoon. Should we can
Yes.
call it that way?
Yeah.
Still, as we are approaching the end of our time, Dr. Dina, do you have any last thoughts or pearls of wisdom that you want to share with the audience and the listener?
Sure, absolutely. So this little part is three simple things that people can do if they're on levothyroxine and they're not getting the best results from it.
Mhm,
Because I get people all the time, they're like, "Oh my gosh, my doctor changes my thyroid dose every time I go in. It's up, it's down, it's crazy, and I never feel good." So, the first thing to remember about that little up down cycle that you have with levothyroxine is that it's really important to take your lab test at the same time of day every day, every time you do it. And so for my patients, I send them to the lab 6 hours after they take their morning dose because I don't want to know what they are at the very lowest of the low right before they take their medicine. I don't want to know at the very highest of the high 2 hours after they take their medicine. I want to know in between. And so,
mhm,
because all my patients are taking their medicine at least twice a day, for me, that's about 6 hours after they took their morning meds.
mhm,
And the key there is consistency because it is going to be a little different every time of the day. And if you forgot your medicine day before yesterday, it's going to look different than if you had been taking it regularly. And especially if you forgot it last night, it's going to look way different. And people get this complacent idea. They think, oh, the half life is 2 weeks. You can just take your test whenever. No, no, you can't. So that's one. And then the second one is what I mentioned about breaking your levothyroxine and taking it twice a day. For some people, the only thing they have to do to feel better is to stop that high low cycle by breaking it in half and taking half of it in the morning, half of it at bedtime. And it's enough to lower their reverse T3 and get them feeling better. And I think that's kind of a weird and interesting thing. And then if you're still not feeling well,
mhm,
then go back and ask to test the T3, ask to test the reverse T3, and do the test at a time. And, like I said, my personal preference, 6 hours after the morning. But ask your doctor to test those other numbers and see where they are, the reverse T3, the total T3, the free T3. Because what I see a lot of times is that somebody who's on levothyroxine will have a T3 that's even lower than somebody who's on no medicine at all and may feel worse. And I've seen that a few times that people feel worse on levothyroxine than they did on nothing. And it's like,
mhm.
no wonder people don't want to take medicine. It's like their doctors
Yeah.
don't understand how the medicine works in their body.
Mm,
But anyway, so that's kind of the bottom line. And then if you still don't feel like it's right, then there's probably something else going on. It could be sleep apnea, it could be cortisol, it could be, you know, your birth control pills have suppressed your sex hormones to the point where they're zero. Um, there are so many reasons to feel crummy, to gain weight, to be sleepy, to be brain foggy. There are so many reasons. So don't forget about those other reasons.
yeah. So let me recap and kind of like the last few pearls of wisdom that you mentioned. So one, compared to maybe what a lot of people might do because it's easier, which is they wake up and before they go to work, they go to their lab and they have their lab test tested, especially because they might have some that are fasting. So everything gets
Mhm.
wrong like at the same time.
Yeah.
With thyroid, and I'm just going to use as an example because it's easier for people. It might be better to go in your lunch,
Mhm.
especially if you are close to a lab, and have your thyroid draw at lunch.
Yeah.
The other pearl of wisdom that you mentioned is so dividing the dose of the levothyroxine in 2 times a day, so twice a day instead of just once a day. Making sure that you know that your T3 and your reverse T3 are getting tested and are getting looked at, and that is being treated if it needs to be treated. Right?
Yeah.
And then finally, what you mentioned, which again goes back to, and if that does not work, what else could be going on in your body? And especially when it comes to hormones, remembering that all of the hormones, of, they work together and one affects the other. So a hormone that can be up here can be affecting you down here and vice versa. So,
Mhm.
hormones are beautiful and complex, but they talk and they communicate to each other. So we want to make sure that communication is in the right path, right? So that you can feel the best that you can in your body. So then, Dr. Boehner, if people want to get in contact with you, what would be the best way for them to do that?
Sure, absolutely. So my website is www.danagibbsmd.com. And that's probably the easiest way to directly get in touch with me. You can send me an email, drgibbs@danagibbsmd.com. I also have a podcast of my own. It's called Beyond the Thyroid, where I talk in a lot more detail and about a lot more of these same topics that we've touched on today. Would love to see you over there. And if you want me to answer a specific question, send it to me at my email and I might make a podcast episode out of you. So that would be pretty cool.
Yes, absolutely. Well, thank you for being here. And then, lady, I will put the link for you to contact Dr. Dana on the show notes. So not only her email, but also her website and the name of her practice and where she is located so that
Yeah.
you can have all of that information available. So thank you, Dr. Dana, for being here. Ladies, until next time, and remember to leave a review wherever you listen to your podcast, because when you do, that helps other women like you find the podcast and get the information that they need and they're looking for a very reliable source. Until next time, bye.